Okay, everybody, I think we're going to get started now. And I just saw clapping hands from Laura going out. Funny. We're going to get started, and I would like to welcome you to another Friday where Stonehill is providing free CE to agents, and we're doing it to show you our commitment to you and your small business. So we do regularly have these CE meetings. They occur on Fridays most of the time, from the tail end of January up through the middle of June, the end of June, when we start getting back into AHIP and we start getting into carriers and we start getting into preparation during third quarter for fourth quarter when we all have our heads down. Today, the purpose of this particular meeting is we've done it in the past, and we've had a number of agents who have asked us for it. They are frustrated with the carriers. And so one of the things that we'd like to do today is we would like to try to convert your frustration with the carriers into curiosity and potentially into insight that can change your behavior and change your thinking, not only with respect to the carriers, but with respect to your clients. We think that those agents who are going to be engaging with what's happening in the industry, and we think that they are not the random walk. We think that they are structural changes that are going to be occurring in our industry and have been occurring in our industry for the last several years. We think that if you understand what's going on in the industry, you're going to do a better job at alleviating the fears and anxieties of your clients. And alleviating fear, as you probably know, is a great way to win and preserve trust. This presentation is going to be divided into two parts. I'm going to present the first part. I am going to present more facts sprinkled with interpretation. And then Bob is going to present, and he is going to have more interpretation sprinkled with facts. And the most important thing, as you probably can tell, is the interpretation, because the interpretation is what decides how you feel and what you're going to do with the facts that are presented here. To a certain degree, the facts that we're going to be presented will probably create anxiety. So the anxiety that you're going to feel, we anticipate, will be more toward the front end during my presentation. And then we're hoping that we can work on interpretations that can alleviate some of that anxiety in the second half of the presentation. Whatever happens here, and we're going to be talking about some critical dates going forward to be looking at. For example, April 6th, when the final rule comes out from CMS. This year could be the most dramatic change to Medicare that we've seen, even outstripping the previous 2 or 3 years. So most of this started back in 2023, and it's just going to be continuing right now. I'd like to mention a frustration that I personally had in making this presentation. And that is, as probably most of you know, people are getting to rely more and more on AI. I'm relying more and more on AI. And the government, it started in the Biden administration and has been followed up by the Trump administration, are denying access to AI agents when you're trying to get information. And I wanted to mention that just because I don't think that the government should be restricting our access to data. We the citizens, we're the owners of that information. Our taxes pay for it, so it belongs to us, and they shouldn't be, doing that. You're going to be seeing some slides in here with some contradictory measurements. And let me give you an example real fast. Some data vendors are reporting that during the last AEP, 2.7 million beneficiaries were compelled to change plans. Other data vendors are saying that it was 2.9 million that were compelled to change plans. Both of those are rounded numbers. We don't quite know what's going on here. So as you're looking at this, please take that into account, that we may be offering you a few inconsistent numbers. The reason that this is happening is we're relying on different vendors who measure the same thing with different results, or we are relying on vendors who are measuring different things and calling it by the same names. And so there's a little bit of inconsistency in the data, and I'm anticipating that those inconsistencies are going to become more pronounced as time goes on, and as people rely more on artificial intelligence agents, and people are able to do a lot of this research for themselves. And so I think I mentioned earlier what those different numbers mean is that our industry is no longer in what the statisticians call a random walk, where things go up and things go down just because that's the way things perform. What we're seeing here are major structural changes to Medicare, and they've not been fully worked out. And the carriers are being buffeted by these instabilities, and the carriers are passing along, because they don't know what else to do. They're passing along those instabilities to us, the agents, to their beneficiaries, and to the providers. Now, the providers are also being buffeted by CMS's attempts to get some things in line. One of them is that in 2025, the government paid 20% more per Medicare beneficiary on a Medicare Advantage plan than they paid for them if they were on original Medicare and or Medicare supplement. Now, this is uniting both sides of the aisle of the political spectrum to recognize how much of a problem Medicare is. And you're going to see some of the measurements that they're taking based on what MedPAC is recommending to them. So one of the things that you're going to see here, and I'm just going to try to prepare you for this, is that the government is not increasing funding to the carriers this year. So the funding that they are providing is basically flat, despite the general inflation and despite the even higher medical inflation that's going on, because they're going to be trying to get that into alignment. Now, what does that mean for us? Well, we're not sure, but we're going to be seeing that as when CMS comes out with their final rule on April 6th this year. And then we'll be seeing that when the carriers come out with their plan designs and perhaps their compensation. We already saw a big impact on agent compensation last year, when a number of carriers, including some of the big ones like United Healthcare and Humana and Aetna, decided not to pay compensation on some of their plans. And we'll be talking about what that is all about. Now, one thing that I'd like to say is we have a lot of information to go over. But I know from looking at many of these presentations myself that if you get a question in your mind and it's bothering you, you have a hard time paying attention to the information that's being presented, because you don't know how to interpret that information because of this question, this nagging doubt that's in your mind. So I would like to suggest that you ask us those questions, because I do believe that what we're going to be talking about here is substantive. It can affect your decisions, it can affect your frustration levels, and it can affect what you're going to be saying to the people you help manage the complexity of Medicare. That complexity being something that Medicare beneficiaries are constantly aware of. And it's one of the reasons that CMS is still valuing your participation, the participation of independent Medicare agents in the whole process of keeping Medicare aligned with seniors' needs, something that happens every year. Okay, so I just want to start out with some general numbers here on Medicare right now. And by the way, I'm going to have the slides up, and I'm going to expect you to be looking at the slides. I'm not going to be going over the numbers in detail, maybe a little bit in detail, but I'll just be touching a point or two. So this year, Medicare Advantage crossed a threshold. And when I say that, I mean 2025, which is they have nationwide majority penetration for Medicare Advantage. Now, it's been that way here in the West for quite a while. In Utah, in Nevada, in Idaho, and some of the other states around us, Medicare Advantage has been the largest portion of Medicare for a while. The rest of the country has been catching up. However, that growth in Medicare Advantage, because of the turmoil in Medicare Advantage, is starting to slow down. So in 2019, Medicare Advantage nationwide was only 36% of Medicare coverage. But that surpassed it, so we're at 54% for Medicare beneficiaries nationwide. Not sure what that means, Alexius. Not sure. Does that mean not sure? Growth slowed down in 2025 to 3.8% per annum, as opposed to the usual 7 to 9% per annum. And this is because carriers are starting to pull back in the benefits and in the attractiveness of the benefits. The Congressional Budget Office is projecting that by 2034, 64% of beneficiaries are going to be in Medicare Advantage. I'm not sure if they took into account, when they came up with that number, the slowing rate of adoption. Now, I just had something else I wanted to say and it slipped my mind. Oh well, maybe it'll come to me and I'll say it back again. This means that you're going to be having more conversations and perhaps longer conversations with your clients. You probably had longer conversations in 2025 than you did in 2024. And you probably are going to have longer conversations in 2026 than you did in 2025. And there may be an ongoing trend here. And if that's the case, then you're probably going to have to start thinking more seriously about having customer service reps working off of your license to help you, or having AI to help you. I know that I'm going to be going fast here because we got a lot to cover. But I do want to have you jump in here if something is really bothering you, because it very well may be bothering somebody else here. This last year, we had greater disruption in Medicare Advantage than we've ever had. So the disruption that occurred last year in 2025, AEP for 2026, was greater than the preceding year, and the preceding year was the highest on record, which was greater than the preceding year, which was the highest on record. So in 2024, 1 out of 8 seniors had to switch. But now 1 out of 5 beneficiaries is having to switch. And so you can kind of see the trend in the chart there on the left. And I would also like to point out a trend here, which is that you are comparing the switching rates between MA and Medigap or Medicare supplement there in the right chart. So this last year, 29% of Medicare beneficiaries in Medicare Advantage had to switch. 2.7 or 2.9 million of them were compelled to switch. With Medicare supplement, we see that only 9% switched. Now we're gonna be talking a little bit about this. So what you're seeing is you're seeing a lot of the Medicare supplement carriers saying that there's much more stability in Medicare supplements. And if you look just at the switching rate for 2025, then that argument is plausible. If you try to make a more complete story, then that argument starts to get whittled away a little bit. And I'll be talking about that a little bit more, and Bob will be talking about that a little bit more. Okay, so what we are in right now, as far as the carriers are concerned, and maybe some of you are concerned, and the provider networks are concerned, is we're in a financial crisis. In this financial crisis, it is mostly generated by what are called the medical loss ratios, or the MLRs. I've got the thing here. This chart here, this left chart, is showing the progression in the medical loss ratios suffered by the Medicare Advantage carriers. Now, most of you know, and because I believe it's part of AHIP, that there is a legal standard, which is that for every dollar that the government pays to a Medicare Advantage carrier, 85 cents of that dollar is to go to the direct benefit through the design of the plan to the Medicare beneficiaries. And 15 cents of that dollar is to go to paying the salaries of the people who work for the Medicare insurance carriers, to go to paying stock dividends, to go to paying the commissions and the overrides of the independent channel, to pay for advertising and marketing. So what's happening as these medical loss ratios are climbing, and you can see that they're climbing, they start climbing in 2022. So this is post-COVID, and we're going to be talking about some of that stuff. They're climbing to every single year, and they're projected to pass 10% this coming year, which means that if you look at how much that means it's going to pass 90% of the benefit going to the beneficiaries, which means that the carriers only have 10% to completely work all of their operations on. So what's been happening here is that in 2024, $5.7 billion in losses was incurred by the Medicare Advantage carriers. So in 2024 already, out of the 435 Medicare Advantage carriers, 265 of them went into the red in 2024. Does that make sense? I hope that makes sense. The worst of the states that are performing this way is Idaho. And so in 2024, so this isn't even 2025, this is 2024, their medical loss ratio up there for the entire state was 101%. That means 101% of all the money that came from the federal government to the carrier, 101% went to the beneficiaries, which means that the carriers were paying 1% of money that they get from other places, of their savings, of their assets, to the benefit of the beneficiaries, which means all of the other expenses that they have for employees and insurance, their E&O insurance and everything, that was all lost. So why is this happening? Down there at the bottom, we see this post-COVID surge in utilization. So this medical loss ratio reflects or shows the increase in utilization. And we're not sure, when I say we, I mean the people who are trying to understand why the medical loss ratio keeps going up, why people are using more and more services every year compared to the baseline, which was established before COVID. Why is this happening? And I don't think anybody really knows. So there's a surge and it keeps going on, and we're going to look at some of the projections of this in just a second. The fact that the GLP-1 drug costs for weight loss have been mandated to be part of what is going on is a big part of it. CMS compressing the rates, and they're compressing two rates. They're compressing the base compensation rate, and you'll see that one is growing at less than 0.1% this year, despite the fact that medical inflation is growing at 6% or thereabouts. And that's all to try to get the carriers so that they're not spending 20% more for Medicare Advantage recipients than they are for original Medicare recipients. Star rating revenue losses. So the star ratings were completely changed with something called the 2-Key method. There were court cases where a number of the large carriers took CMS to court. They lost. They, being CMS, lost that court case. So the star ratings are still under pressure. They're still not completely stabilized. But the ratings, the way that they are being implemented, means that the carriers are actually earning billions of less now per year from the government than they did in the past. There is there's a backlash against using AI for prior authorizations, and we're going to be looking at that. There's all sorts of litigation in that. And then the Inflation Reduction Act, which has it so that I hope everyone sees Larry's note popping up there. So you may have to mute your mic, but then you can just click it when you want to make a comment. Just jump back in. The Inflation Reduction Act took the maximum out of pocket for the beneficiaries to $2,100 in 2026. But that means that either the carriers or the government or the drug manufacturers need to digest that. And all of them are doing their absolute best to make sure that it's not them and it's the other parties that digest it. So all of this is contributing to some of the financial crisis that's going on. Okay, so what I'd like to do very quickly, if I can, this is a CE. It requires us to ask you questions. We are required to ask questions at the end, so there will be 3 questions that we ask you in polling, which is a feature here in Google Meet. For those of you who have a hard time with polling, we will be reaching out to you if we see that you didn't answer the polls with email so that you can do it by email. But we also have questions, so we're going to ask some of the questions at the end through polling, but we have, because it's a 2-hour, we have more questions that we have to ask. And we're just going to ask those Okay, people already know what's going on. They're already answering in the chat. And I haven't seen a wrong answer yet. So that's great. Man, I didn't even finish saying what I was saying, and y'all read my mind. Okay, so we're just going to move on. If you haven't answered, please answer. Okay, so another question that is that you may have in your mind is how are the executives, the C-suite, responding to this stuff? And I don't know if you know or if you remember, but there was a CEO of United Healthcare that was assassinated in New York City because of what's going on. And then his boss, the CEO of United Health Group, which are the largest carriers and the largest health-oriented companies in the United States, Andrew Whitty resigned from CEO last year as some of this stuff started to hit. So what we have here is we have some quotes from the largest national carriers in the Medicare space. So the CEO of United Healthcare, his name is Tim Knoll. So he's not, Lisa, you'll get to the polls at the end. So we have to do the polls at the end. It's a way of ensuring that everyone stays for the entire CE. We have United Health, and I'm not going to read what they're saying here, but we have the CEO, Tim Noel, or Noel, I'm not sure how you say his name, talking about things. That's not the CEO of the entire United Health Group. And I don't know if you know this, but United Healthcare has completely restructured how their Medicare operations work. So now they have a CEO over government health. And so that means this CEO is over anything that CMS is regulating. And so that's Medicare, Medicaid, and I assume, I don't know this, I haven't looked at that, but I assume that it's also over Marketplace. You can see some of the things that are happening here. I'm going to let you read the stuff on the left that they're actually telling the investors. And I'm just going to talk about some of these things. In particular, I want to talk about Humana. Humana is probably suffering right now, but we don't know the results of it. And the reason that they're suffering is because they picked up more new clients in this last AEP, and they're picking up more clients right now because they decided that they wanted to try to grow their market share. And so when everybody else was designing plans by taking out benefits, they left their benefits in, their rich benefits in. And in particular, I'm thinking about dental and things like that. So what we have is as you'll see here below, Humana, just in Utah, they grew by 50%, while almost everybody else stayed stable or shrank. In practice, what that means is that United Healthcare and Aetna were trying to stop agents from selling to their risk pools that had adverse selection. And they knew that they had adverse selection because of the losses that they were suffering in those risk pools. And so they decided not to pay commissions on those. Most of those turn out to actually be PPOs. So you're going to be seeing a decline in PPOs this year. And you already saw it last year. The PPOs that are staying on the books often have no commissions being paid. And so what's happening is the people who were forced out of these planned closures, or the fact that there were no agents that were willing to write it because they wouldn't be paid, what's happening is those people, the adversely selected people have moved to Humana. So Humana, we're seeing huge numbers in the rate of enrollments, but we also know just through common sense, not that any marketing organization has told us this yet, at least at least not with hard numbers. Excuse me. Common sense tells us that they are picking up a lot of those adverse selections. And you can see here, one of the implications is that the EPS guidance, the earnings per share guidance, it was expected to be $12, and now it's a disappointing $9. And that's the guidance that they're being given. Okay. Here's markets at a glance, and I did focus mostly on Utah, Idaho, and Nevada, though the fact that I was using AI agents to help me on this means that I do have one or two holes in this data, and you'll see some other holes in some other data as we go on, and I apologize for that if any of you are from Idaho or Nevada. Most of you are from Utah, so I did spend most of my time trying to get through the barriers pertaining to Utah, and I just didn't ever have time to get to those pertaining to Idaho and Nevada. But if you are from Idaho or Nevada and you need me to work on the stuff that you'll see, I'm certainly willing to do that. What you can see here is I'd like to point these things out. So these, you can see the numbers here. The total Medicare beneficiaries, those are the people who are on original Medicare or on original Medicare plus Medicare supplement or on Medicare Advantage there in the top line. You can see the MA penetration rate per state. Each one of these states has more Medicare Advantage people than they do group Medicare. By the way, group Medicare is growing quickly as well. I'd like to just call that to your attention. The opportunities for getting the new to Medicare commissions mostly now are in selling into groups and to people who are turning 65 and continuing to work. If you are continuing to do consumer marketing, you are mostly going to be getting mostly renewal and replacement commission rates. We've been here at Stonehill, we've been pushing the notion that you need to start thinking about business to business marketing. Many of you are older, just like I am. And so the thought of having to change your marketing and everything completely is a little overwhelming. And we understand that. But if you do know people who you are interested in selling your book to, and if those people are going to be younger, I think that you need to start thinking about how to increase the value of what you're going to sell by starting to at least have thinking, starting to at least have processes that pertain to business sales. You're talking to the small business owners or the small business HR people so that you can be talking to their T65 who are continuing to work after they turn 65. You can see some things here. You can see who the dominant carrier is in each of those states. You can see the loss ratios, right? So the loss ratio in Utah is less than the loss ratio in Idaho. And I was not able to, despite my strong efforts to get a loss ratio for Nevada, I wasn't able to say it. Based on the richness of the benefits in the Nevada market, I mean, the richness of the Nevada market just is crazy. It suggests to me that their loss ratios are in control, that the people down there, for some reason, are not using, utilization rates in Las Vegas and Clark County are not going through the roof the way they are in the other states. Less so in Utah than Idaho. In Idaho, it just went crazy. And as you know, many of the MA carriers in Idaho were forced out of the market. Some of you may have read there are about 10 states where the provider networks are basically saying, we do not want to deal with Medicare Advantage. So that's another thing that's going on here that we haven't really talked about. In some states, the provider networks are tired of the games that the Medicare Advantage carriers are playing in order to keep their noses above the water. So what's happening is these Medicare Advantage carriers are under so much stress because of all those changes that are occurring that they're trying to make the provider networks cover it. And the provider networks are saying, we're just not going to deal with you anymore. We have counties with no plans in all three of these states that we're sort of focusing on. You can see here how many people have Medigap plans in these states. Now, these are estimates back from 2022 or 2023. I tried to nail down what these estimates were, which year they were in, and my AI agent just couldn't quite nail that down for me, and I didn't want to pay the what I consider to be the exorbitant fees that some of the data brokers would have asked me to pay to get that. I felt like if you had something in the ballpark that would be good enough. You can see that most of the states in the past have had a attained age as the Medigap rating method. That was getting so crazy. I mean, the prices were getting so crazy for everyone in Idaho that they changed it in 2022 to a community rating. So that means that the older people are not going to be paying $350 or $400 a month for their single Medigap coverage, but they're going to be paying a lower rate, even though the younger people are going to be higher rates. You can see that there are no under 65 Medigap requirements in Utah nor Idaho, but there is as of 2025 in Nevada. Okay, this is quickly sort of showing the what happened with AEP in Utah. I do have the data for Nevada and Idaho, but I have not had a chance to get my AI agent to pull it out in a comprehensible way for you. If you do need those things, I am willing to get those for you. So what I'd like to point out here is that United Healthcare, you can see they deliberately lost 2.4%. Well, they had a negative change in their enrollments of 2.4% or 3,100 people. And this was deliberate on their part. They are deliberately retrenching. They are trying to reduce the number of people that they have on their books, the number of lives they have on their books, in order to start giving profitability a larger attention. United Healthcare did lose 42% of their stock price in 2025. Their capital, how much the company is worth was reduced by 42% because of some of the issues that are going on here. And we're going to be looking at them a little bit more, just because so many agents in our marketplace have relied on United Healthcare. United Healthcare has been the bread and butter. People have wanted to get on United Healthcare, learn the United Healthcare system, and then really not bother learning about some of the other systems that are out there. I have mentioned Humana. I want to point out Humana in Utah grew by more than 19,000 new beneficiaries. That's almost a 49% growth in enrollments. But that is, we now know that was taking the people from Aetna, and you can see Aetna is down by 7,307. United is down by 3,000. Most of those people went over onto Humana. And those people were, what's the right word? Those people were invited to leave Aetna and United Healthcare because of the impact on the medical loss ratios that they were having. And so those people now have moved over to Humana. Regents, you can see they stayed rather stable, rather constant. This was a little surprise to me. I was expecting them to dip, but the brand name of Blue Cross Blue Shield continues to deliver for them. We have been told, many of you have, okay, I'm just looking at Cynthia's question here. I need to go and look at the full question. You know, I don't know the answer to that, Cynthia. I imagine that had somewhat of a effect on it, which we mean in that it's a rational decision by decision makers, by Medicare beneficiaries. And my impression is that most of the decision making by beneficiaries is no longer calm and calculated. The only way it's going to be calm and calculated is if the agent that they are with is able to enable people to make calm and calculated decisions. Most of the decisions this past year, and starting all the way back in 2023, have been more anxious and stressed decision making. So Regents did come in. We have been sort of told a number of you are having difficulties seeing Regent in your Integrity Connect software. And we have been trying to get that fixed. And in the process of trying to get that fixed, Jennifer, I'm not sure what the thumbs down was about. Oh, I know what the thumbs down. That's about getting the Regents fixed. We have been told that they are trying to get their stuff worked out, that they're sort of in a holding pattern, and they would prefer, rather than spending time on getting little things like getting Integrity Connect fixed, they want to spend it on changing their operations and how they incorporate things. So there is a little frustration out there that they're not getting that particular aspect of their stuff fixed. They are not trying to grow. Regents is not trying to grow, is what I've been told. They're just trying to march in place until they get their ducks in a row. Most of you are not concerned about Molina. Most of you are not concerned about HealthSpring. You can see HealthSpring is down. They lost about 1,000 people. They have not been reaching out to me and not making a big deal, so I'm not going to spend much time on them. I do want to take just a second to talk about Devoted. I don't know how many of you are paying attention to Devoted. They have sort of a odd footprint. They are in the Wasatch Front, running from east to west. In other words, they're in Tooele County. They are in what's Park City? Is that Summit County? They are in Summit County. They are in Salt Lake County, but they are not in Utah County. They are not in Weber County. And the reason that they were not is because they thought they were going to be, but then they were not able to recruit enough people, say like neurosurgeons, for CMS to qualify their network in those counties. They're working to do that. But here's one of the things that if they are in your area, that they actually have a competitive advantage in that you may want to consider. I'd like to remind you that several years ago, I think it was Kaiser Permanente or United Healthcare did a marketing survey, And it was when, I don't know if you remember, but a number of the carriers came out and said that they had simplified Medicare Advantage. And, if you wanted simplicity, please go to the carrier. Those advertisements were only on 3 to 4 months, and then they were pulled because they didn't have a good definition of what simplification was. But there was a marketing study that was done, and they found out that Medicare beneficiaries dislike the complexity of Medicare Advantage so much that they would prefer to have a root canal or a colonoscopy than have to make decisions regarding Medicare every year during AEP, right? Whether that be just a PDP, whether that be a full MAPD. So it looks to me like Devoted has taken that to heart. And what they are doing is they are operating with a different insurance model than, say, United Healthcare or Humana or Aetna or Select Health. They have something, they are actually trying to take the complexity out of the minds of their beneficiaries and put it in the minds of primarily their customer support people. So their customer support people are more empowered than everybody else. It's sort of concierge customer support. Molina's tried to do this a few years ago. I don't know if it succeeded. But what it does is you call their customer support, and they're called Devoted Guides, and they have been empowered to solve all sorts of problems for their beneficiaries that the customer support people in other companies have not solved. To support that, they've rewritten their software. They've rewritten their software. Their software does things that none of the other insurance companies do. Their Devoted Guides, their customer support, have access to this. They can see the claims made. They can see the procedures. They can see everything. And what it means is that they are worth considering if they are in your service area, because they may be a good solution for reducing some of the increasing burden that's going to be placed on you that I mentioned at the top of the presentation, where you may have to get better at using AI agents. And there's some pretty good ones that have come out over the last 4 to 6 weeks. Anyway, they're worth considering. So I just wanted to put them on to you. I did also want to, do I want to mention this here, or do I mention? We'll mention, no, let me mention it here, and then if we mention it again, because this is one of the big things. You guys have been hearing about prior authorization disputes between provider networks and carriers. That has risen and to the point where the government has decided to step in and manage that. So that CEO of United Healthcare, he was assassinated because they were using AI agents to do prior authorization, and they were having it deny at 90%. And we're going to talk about that in more detail here. So I'd like to have it mentioned several times. I'm going to mention it another time. I think Bob is going to mention it. But one of the things that's going to be happening here as of March 31st, the carriers are supposed to be reporting how they, okay, Bob, okay, I got it. I'm gonna rush. The carriers are going to be required to report their prior authorization denial rates and to tell beneficiaries and agents how they make those denials. So that's worth considering here. I'm just going to let you look at these. These are sort of an overall financial health of the various carriers that are in the market. You can see I've covered all 3 of the states. Regence is only in 2 of the states that I'm covering here. I would like to point out that United Healthcare is retracting, and that is to protect themselves. They are under not only civil investigation, not only securities investigation, but they are also under criminal investigation because of some of the things that they have done over the last several years. Okay, how much time do I got? I've got 4 minutes. I'd like you to notice here the star ratings. I'm not going to spend much time on this. You can see the star ratings. The average was 4.37 in 2022. It's projected to be 3.85 at the end. That constitutes billions of dollars that are lost. In the left there, you see Humana's star collapse. They went from mostly 4+ star ratings. They went all the way down. So now they only have 20% in 2026 who are in 4+ star rated plans. You can see the number of plans that went from 5 stars. There were 74 plans in 2022. And this is all part of the reformulation of the star ratings and the 2-key method, which is now under, government, court oversight.
Doug, can I make a quick comment?
Yeah.
So I'd heard something just the other day regarding star ratings and the way that they're calculated. And in the past, star ratings have been calculated based on a lot of factors that were kind of subjective, I guess. And that's going to be changing. And so they're saying that star ratings are now going to be based primarily on customer feedback.
So a lot of the subjective stuff that you were talking about was customer feedback, and what it did is it created outliers. And so now they haven't said customer feedback is not important, but if it's an outlier, it gets cut off. So they're looking at sort of the standard deviation in order to come up with it, and that's the part that the courts have said, we're not sure that's legitimate. So that's what's happening. But I appreciate that, Gene. Okay, let's talk a little bit about Medicare supplement. You'll see a lot of positioning that it's a safe harbor because the switching rate is so much lower than Medicare Advantage. The problem with it is that utilization increases are hitting these guys as well, particularly in the West. And so what's happening is that the Medigap insurers are having to go to the state departments of insurance and asking for rate increases. And they're asking for large rate increases as they seek financial stability. And the departments of insurance are looking at it from a consumer perspective, and they are turning down the rate increases. For example, I understand that one of the carriers in Idaho went to the Department of Insurance in Idaho and asked for a 32% rate increase. And the Department of Insurance denied that and allowed only a 20% rate increase. Now, when the beneficiaries see that 20% rate increase, they're going to have a heart attack. When that carrier gets the fact that they needed 12% more to remain financially stable, they're going to have a heart attack, or they did have a heart attack, right? And the beneficiaries did have a heart attack. You can see there in the pie chart a little bit about nationwide how much the different carriers have in market share. That largest slice of the pie there are innumerable Medicare supplement carriers that are in that. They are, and I didn't confirm this, I didn't have a chance to confirm this before, but the reinsurers for Medicare supplement carriers, they were refusing to take on new Medicare supplement carriers because the reinsurers decided that they already had enough risk in that. So it'll be interesting to see what happens. This is more of the structural change that's occurring here. And this is a big deal, but I'm not going to spend much time on it. Here I'm going to say rising utilization is what's causing the structural shift in this. By the way, we can send you copies of this presentation. We can send you copies of the presentation if you wish, and we will have recorded this so that you can watch it again if you wish. But in order to hit what I need to hit here, I'm going to be leaving some of this stuff to Bob to cover. So we're going to take a break. Sometime in the break, we're going to come back at 11:05, and then Bob is going to be taking over. During that break, please take and respond to this, and then we'll be good to go. So okay, let's take a break, and we'll see you back here at 11:05. Thanks, everybody.
So I have 1 minute to tell my joke, Doug.
You do.
All right. Well, I'm going to tell my 1 minute joke here, but it probably will go longer than that. But the story is a little old lady got pulled over on the freeway. She'd just been through the concealed weapons class, and as soon as the highway patrolman got up to her window, he asked her if she had any weapons in the car, and she said, "Well, actually, I have a Glock 9mm in the console here." And he said, "Okay, that's fine. Just keep your hands on the steering wheel." And she said, "Well, wait a minute. I better tell you, down on the driver's side in the little pocket, I've got a Smith & Wesson 45." And so, of course, he asked her, "Well, are these loaded? These guns loaded?" And she said, "Well, of course they are. They wouldn't be any good if they weren't loaded." And he said, "Well, keep your hands on the steering wheel." She said, "Well, wait a minute. In the glove box, I better tell you, I've got a little 380 handgun in the glove box." And I said, "Well, lady, just keep your hands on the steering wheel and we're fine." She says, "Well, I better tell you, under my seat, I do have a 10mm Glock under the seat." And he was exasperated, and he said, "Lady, I'm just curious, what in the world are you afraid of?" And she looked at him in all seriousness and said, "Nothing at all, officer, nothing at all." Anyway, with that, let's get into interpreting some of the numbers we looked at, maybe take a closer look at a few things. So go to the next slide, Doug. So these are some evolving decisions that are affecting you as an agent and your specific market. One thing you need to be aware of are these things. And again, Doug will be, or the office, Stonehill will be sending you a copy of this so you can look at them more closely. But one of the things I need to point out is that Doug and I took multiple articles and tried to boil them down for our presentation. One thing I thought I saw was it's almost looking at the Bible. You could interpret them several different ways, and if you're not careful, a lot of times there's contradictory things there. We went through a lot of material to come up with this, and there was a lot of variation from article to article. But some things that are really important to know is that Medicare Advantage compared to Medicare Supplement, the feds are really trying to get that more evened out. Medicare Advantage, a lot more money being expended on Medicare Advantage than regular Medicare. And that is affecting everything going forward because they're really trying to get a handle on that. Forced disenrollments. 1 in 10 enrollees needed to disenroll due to insurance, to carrier exits going on last year. And we all saw that. We saw that with different carriers. We saw that with Select Health kind of going to just the I-15 corridor, but exiting several counties. We saw that across the board. Select Health was not the only one that was exiting. I think the rural counties, for the most part, got hurt the most. And when I say rural counties, I'm talking, people outside of the Wasatch Front, people out in the what I call the hinterlands, even Tooele, which you wouldn't think Tooele would be really affected because of the population growth out there. But we also saw about a little bit more than 10% increase in Part B premiums this year. I don't see that. We don't see that as something that is going to go down. If anything, it's going to go up. One of the reasons why is we have, as you all know, we have an aging population, and everything we've ever read before shows that Medicare utilization increases with age, and with an aging population, that is going to be that's going to affect utilization, which affects profitability of the carriers, which in turn, if they're not getting increases from CMS, from the feds, that's going to have a real impact going forward. So go to the next slide. If I go a little bit too fast, everybody, somebody slow me down, because I'm trying to keep this on the clock. Next slide, Doug.
Okay, can I just point out the bottom bullet on the left column says that 7 states, Vermont, Wyoming, New Hampshire, Idaho, Minnesota, Maryland, and South Dakota, all their Medicare Advantage percentage dropped. And so I know that some agents have noticed that.
Along those lines, we saw a real decrease in Medicare Advantage participation up in Idaho, and it had a lot to do with, I know a lot of us think that birthday rule is great, but if you've got a state that allows people to go into med supplement without any underwriting, I think what's happening is carriers are buying claims because somebody gets a very chronic, serious health issue. They look at the dollars and cents, a simple math equation, and they see that med supplement might be a better way to go. So some of the effects, this is across the nation. There's great disruption in the EMA space. We saw it here locally with benefit cuts. We saw market exits. And one of the big ones is the risk model changes. And we'll discuss that a little bit further. But the CMS reimbursement changes have really affected the carriers. Next slide, Doug. Here we go. National carriers that lost membership during AEP. One of the things that jumped out at both Doug and I as we went through the different reports that we dived into, United Healthcare had because of their place, their guerrilla stance, their being the big gorilla in the marketplace across the country, a 9% loss is that's really hard for agents across the country to number one, digest with their clients. That affected that. I think that 9% decrease with United Healthcare rippled across the marketplace. The big one though was Elevance, and that was they have the Anthem brand. They had one of the steepest declines among all the national carriers. And then we had Aetna, and this is a national number, 2%. But in Utah, we saw a much larger loss by Medicare, and that was due primarily to number one, agents had to rewrite everything. All their plans got new contract numbers with CMS. They did plan X's. They did products or plans that were non-commissionable. That's the way a carrier slows down growth, is if they aren't going to pay commissions, you're not going to have agents promote their plan. So that's one way a carrier really slows things down, is by not paying commissions. And we saw that with a couple of other carriers where they had specific plans. Again, they did that because they did. I was asked this several times over the years, why do carriers do that? For a carrier to terminate a plan in an area, there's a lot of red tape they have to go through with CMS to actually terminate a plan. But the easy way to do it is to quit paying commissions. If they quit paying commissions, that slows the plan growth. Well, they don't have a plan growth. It's anything. It's just a little trickle because agents aren't going to promote that. I saw a study the other day that showed that if people enroll through Medicare.gov, they don't go through an agent, but they enroll through Medicare.gov. They only saw plans in their areas. They had no idea about the need for an agent, so they just enrolled in Medicare.gov. So that little bit of trickle that Aetna might have seen, it was suggested that was from people who were enrolling directly through Medicare.gov. Next slide, Doug. So this national or regional carriers had the largest growth. This is a national look. And of course, here in Utah, we only have one specific regional carrier, and they lost membership. But across the country, regional carriers had the largest growth numbers. So the question is why? And as you go through everything, I think the understanding or what beneficiaries see, if it is a regional carrier, the regional carrier has their finger on what's going on a more local level, and they're able to adjust to what they see. So it's, I think that's something we're going to see as we go forward, that regional carriers with beneficiaries, there's more traction there. The big player in the regional carrier market, so to speak, or the share, is in the special needs planned area, because that segment of the market really grew. I know in the past a lot of agents have stayed away from the special needs plans simply because it was thought of as a high maintenance plan, meaning that beneficiaries could make multiple changes throughout the year, and agents don't look at it as a stable part of the market. So a lot of agents steered away from that. Has any of you agents out there, what's been your experience with special needs plans? Has it been a positive for your book of business, or created more work for you? Very curious.
I like the special needs plans, and I feel like so I do get business with the special needs plan because I feel like it gives them the extra benefits that they need. I mean, even you have to go some extra steps with them, like get the form filled out with the doctor, but I do help them with that process to make sure it's there, within the 30-day mark as well.
So Colette, do you see much movement after you get somebody in a special needs plan moving from one plan to another? Do you see that during the course of the year? I'm curious.
No, they want to stay with it. They don't want to lose it.
Is there a special needs plan that you think, in your opinion, with all the beneficiaries you talk with them about, is there a specific plan that you think is a strong one, your go-to?
Well, we had only United Healthcare for a while, only with the special needs plan in Utah. So I wrote more of that, but now we have a couple more that have popped up that I've put people in. But mainly I've been doing the United Healthcare just because they've had it there for a couple years.
Now, are you talking chronic illness or DSNP?
Well, I'll do both. But I'm talking about the chronic special needs plan. I do a lot more of the United Healthcare chronic one, and then it's either United Healthcare or Humana I'll do on the dual special needs policy. But United usually does have a stronger benefit with like the extras that they do. Just even with, they can use the extra card towards like power, gas. They can even use it towards rent. There's different things that they can use it towards, and a lot of people like that.
On your chronic needs plan, as you look at your clients, which is the primary health issue that they're facing, the most common?
Diabetes.
And are those usually people who are insulin dependent or just diabetes as a whole?
Diabetes as a whole. I've had
Great.
some that are not on insulin and they still qualify.
You know, one of the things I found is that a lot of diabetic beneficiaries, their physicians put them on these make it easy, expensive medications. My diabetic doctor has me on Mounjaro, and that is, I think that has affected loss rates too, because those are expensive drugs, and I think we see that. I think we see that across the board.
Yeah, and those
now,
are expensive because they're the tier level.
Now, I know that I just saw a thing. I attended a pharmacy webinar here about a week ago, and most of those, like Mounjaro and Ozempic, are going to a oral medication. They have stuff before the FDA to get approval, and they think that will drive the cost down dramatically on those injectable ones, like I'm on. Let's go to the next slide, Doug.
Okay. By the way, there are lots of good comments in the chat feature about C-SNP and D-SNP.
What are there some there that are particularly interesting that you've seen, Doug? Because I don't see them on my screen.
Let me just go back and review real fast. So Bill Turner says SNPs are negative. I take it he means both D and C. Sid Haycock says I've avoided them altogether. Hassan says it is more work, but they are good for beneficiaries. Cynthia says we need to distinguish between D-SNP and C-SNP. Bill says it's all about get what I deserve. That sounds more like D-SNP. Alexia says I avoid them. I'm too old to learn more stuff. And when I talk with agents, that is a common theme. Bill says amen to Alexius. Lorna says C-SNP positive except for dealing with UHC's junk eligibility verification. Micah says not been selling them. Jennifer says amen to Lorna. And then they're answering the diabetes versus heart conditions as the most prevalent condition. Jennifer says diabetes.
I just saw something from Brady. Brady, unmute your phone and talk to us a second. maybe he can't do that. What was his? He just had a remark that I thought was
I've
very
had
good.
great experiences with D-SNPs as long as you do the work to make sure that they get the right plan.
Yeah, I think that's a real speed bump for most agents is the extra work to do those. So let's talk
Brady
about
does Brady does say, "Sorry, Bob, my mic's not working." So.
Yeah, I saw that one. Let's talk about
Okay.
growth in the Utah Medicare space for a bit. Humana enrollments, they increased 49% across the state. And the first question is why? Why did they have such an increase? And I think that boils down to several reasons, one of which is that Part B give back. I know there are some agents that were unaware that Humana had I think it was a $77 per month give back. And I think if that was presented, or if clients found that out, that would be a real incentive to move. And I'm going to step back in time. When I first got out of the medical device industry and got into insurance, I was hired by, I don't know if you agents remember this guy, Dr. Desai had the any plan out of Florida. And it was 100% Part B give back. And I didn't know anything about Medicare when he hired me. And I remember going to a meeting, it was up in Ogden at a big hotel ballroom, that old hotel on the main drag there in Ogden. And the room was standing room only. And we had about, I think we had like 10 agents in the back of the room. And that was my first experience with Medicare. And I'm going, holy smokes, I've been in the wrong place. People were lined up to get that any plan. Of course, that only lasted, I think, for like 2 years. And then it went the way of the dodo. But that was a big incentive back when I first started dealing with Medicare, was that any plan. The idea of being a PFS plan, the idea was any provider, anytime, anywhere. And then that was appealing. That was appealing to beneficiaries, as well as that I think at the time it was $120 a month give back. That was a big deal. The other thing Humana had is they had some PPO plans where a lot of carriers were pulling back. So it provided an opportunity. If beneficiaries liked the idea of a PPO, that was a real incentive. And Humana actually had a very, very robust provider network. Humana saw the best increase of all the carriers, and that was across the country. UHC lost membership in Utah in every county, 3,100 lives. Regions, as you know, stayed flat. They did pick up a few, they had some trickling. I think a lot of those with my own little teeny personal book of business, and I only write friends, relatives, and referrals. I don't market myself at all. But there were some counties where Regents was the appealing plan simply because of agents or loss of plans in an area. I had two couples up in Box Elder County that lost their Select Health plan, and they wanted the network of Regents. And I had some people here in Southern Utah who traveled. I'm in St. George, most of you know that, and I'd say a large percentage of the senior population in St. George are snowbirds, and they like the brand recognition with Regents, with that Blue Cross Blue Shield. They feel like they can travel anywhere in the country. They show that card, and they're welcomed in with open arms, and that's the perception they have. And I think they have a lot of people do that. Lorna, I've not heard about the grocery card. That is specifically SNP, except if you do have a chronic illness. Select Health, they went from $60 a month down to $30, but you have to be able to have it verified that you have a chronic illness. Where last year, they gave that to everyone without any verification. The big winner down here in southern Utah was Select Health. And I think it had a lot to do with the integration of IHC, not only in Cedar City, but St. George. That has been a real positive for Select Health down here in southern Utah. Devoted Health, Doug talked about them for a little bit. They gained 1,000, and if you dig into Devoted, if you look at their benefit structure in the states where Devoted Healthcare, that they're late to the party here in Utah, but across the country where they've been a while, they get very high marks from beneficiaries and consumers. The biggest thing that was hard for Devoted to get past too was network issues, limited growth, but they're looking to really improve that. I went to a Devoted webinar here about 2 weeks ago, and they talked specifically about their expansion, and I think they're going to do well here in Utah. But that brings us the Devoted coming into the market. That is a nice thing to think about, because for years and years and years, the carriers in Utah, that pool of carriers has been shrinking and shrinking down to just a handful. And to see somebody else come into the market, I think that bodes well. I think that bodes well for our marketplace. HealthSpring, I believe they've gone through a new brand name, but they lost quite a bit of their membership. Cynthia, what did Cynthia ask something? I missed it. Doug, did you see it?
Yeah, what counties is Devoted expanding to? Do we know? So
I've
my
heard.
understanding is, go ahead, Bob.
No, go ahead. Go ahead. You probably have a better
I was
idea
going
than I
to
do.
say they're trying to expand along the Wasatch Front, the north-south. So right now they're an east to west. I've never seen a footprint like theirs. So they're trying to get into Utah County. They're trying to get into Weber County and everything. They just have to build up the network. And with a lot of the turmoil among the doctors, neurosurgeons retiring, et cetera, they're having difficulty getting a network that qualifies. Though I have heard that Medicare may be relaxing some of the stringent requirements on Medicare Advantage networks.
So one of the things I have heard is Devoted they're looking at primarily Wasatch County, that's St. George market, simply because of the growth down here, not only with beneficiaries.
Wasatch or Washington County, Bob?
Washington. What did I say?
You said
I
Wasatch.
thought I said I meant Washington County. They're looking at Washington County, not only the growth of number of beneficiaries down here, but the growth of the medical provider network, or not network, but participants is growing. One of the things that's growing down here is there is a doctor of osteopathic medicine college or university, however you want to call it, down in Ivins, Utah. And they've been announcing in the media down here that they're moving to a inpatient, to have inpatients in their facility down here, which would be in direct competition, I think, with IHC. So I think Devoted is looking at increasing or expanding into Washington County. The big player besides Washington County is Iron County. They have a IHC has a large presence in Iron County. I won't be surprised if Devoted, if they could get a IHC contract, if they didn't move there as well. So some major takeaways. Some of the major takeaways. Nancy just said the voted rep will be presenting next Friday. That's great to know. The erosion of carrier footprints, plan exits, rewrites, limited PPO opportunities, benefit reductions, and agent commissions have all affected the Medicare space. Next slide, Doug. Here we go. Now, Doug touched on this a minute ago, but this is a really important slide. If you look over on the left side, you'll see that there's been an AI, artificial intelligence denial controversy. And if you go down to the 4th bullet point, you'll see that AI in healthcare legislation in California, and there are several states that are looking to see what California did. And as I dug into that, there is bipartisan support of assuring that the actual people are involved, because United Healthcare's algorithm, 90% of appeal denials were overturned. Now, I think that's concerning to beneficiaries, because if they think there is this high rate, a large number, a high rate of beneficiaries who get denials never appeal. They don't know the process. But I think what is important to understand is that with the algorithm UHC has, 90% of appealed denials were overturned. But again, if you look at the use of that, that's only 0.2% of members ever appeal. I think that's an important thing to understand. The Senate investigation of UHC post-acute denial rate rose from 10% to 22%. And you're looking at other numbers there. CVS's AI tool is projected at to save 77 million. That AI is interesting. One of the things I find when I talk with my very small book of clients, the one thing they really dislike that I hear over and over is, I hate talking to someone in another country who I cannot understand. And we only presently in Utah, we only have 2 carriers, I believe, that most of their customer service is taken care of here in the States. And I think that's, to a lot of beneficiaries, especially as they age, they're more into making sure that they can understand what the customer service people are saying. So if you look over on the right side, you're going to see transparency revolution is going on. This means agent opportunity. If you look at the very last in purple down here at the bottom, March 31st, this is a really big deal. For the first time, agents will be able to compare plans side by side on prior authorization approvals and denial rates. Can you imagine the power that gives you as an agent and how important you are to your clients? If you can provide that information, I think just really, this really brings value to you as a agent. I think it's over the top value it brings to you. Next slide, Doug. Here we go. Adverse selection affecting Medicare supplements and Medicare Advantage. Again, we talked about supplements, that birthday rule up in Idaho. I think it's a good case study. All the loss of plans up there, and it was, to make a long story short, that birthday rule allows people to move without underwriting. And I think that is, we always say, carrier, if they do that, they're buying claims, which affects utilization, affects their financial stability. and is something that bleeds over into the Medicare Advantage field, simply because if you have someone, a carrier who has both subs and Medicare Advantage, if they're looking at the overall financial stability, their losses that they're suffering are going over, are affecting the Medicare Advantage side of the house. Increased utilization. We have all seen the numbers as agents that show that as people age, their use increases. And I think that utilization is a direct result of people aging and needing more health care as they age. I mean, we've all had clients, I think, who say, I don't know why I need to have a PDP. I don't think I should be penalized if I don't get that. I don't use any drugs. Well, that number, as the population ages, starts to disappear. So some of the things that Humana is doing is they're very aggressive on home visits, and I think we're going to talk about upcoding in a few minutes, because upcoding, that's one of the things that some of the carriers have gotten in trouble for. But post-COVID, the attitudes have changed with people seeking healthcare, and I think that has increased utilization. Again, that last part on there says, Alexis, the bullet point confuses me. Can you jump in on that, Doug?
Which bullet point?
The very last one. Why are MA plans costing the government 20% more than original Medicare?
Oh, okay. So actually, so the question is, Alexius, there has been apparently an attitude change in Medicare consumers. And so when COVID ended, COVID suppressed use of the services, right? So COVID ended, and everyone was expecting a rebound, and the rebound occurred. But then they expected the rebound to decline back to regress toward the mean, back to the expected usage of services that had existed before COVID. But what actually happened in the effect is the increase in utilization has increased every single year since then, and people are trying to figure out why that's happening. And I haven't read anybody who says, "Oh, we figured it out. Here's what it is." There's just this change in attitude toward medical services that I still don't understand, and I'm certainly not the expert, but I can't shed any more light on it than that, Alexius.
Great.
Okay.
Let's go
Thank you.
Let's go to the next slide. The clock is ticking. The Utah Special Needs Plan view, approximately there are 36,000 statewide eligibles. Select Health had a massive growth on the SNPs.
Is this DSNP? Is this DSNP, Bob? Do you know?
It's both DSNP and CSNP.
Okay.
So what we're seeing is strong integration with IHC in the SNP view. United Healthcare grew, Humana grew, others like Humana or Molina had growth too. The takeaway here is the SNP market is growing faster than the general Medicare Advantage population. Next slide, Doug. Government rules affecting Medicare sustainability. The Inflation Reduction Act shifts much of the final financial burden and downside risk from government to the private sector. You know, the big one was that $2,100 on the RX max out of pocket. A lot of people are unaware of that Medicare RX plan, spending plan, or smoothing payments. I had a client call me first part of February because he likes Aetna a lot, and his first bill was his first pharmaceutical was out of this world because he's using tier 3, 4, and 5 drugs, and that $615 deductible hit him right in the pocket. And I had advised him about getting into that. They call it smoothing out the payments. If he would have, if he would have taken advantage of that, and I did present that to him, but he didn't realize the effect that would have. But that would even out. You divide the 2,100 by the 12 months, you can smooth out that $2,100 down to 100. I think when I did the math off the top of my head, it was like $167 a month, which is doable to somebody rather than that huge deductible upfront. We talked about prior authorizations. The CMS risk adjustment model has completely integrated what they call model version 28, which replaces the old version 24. What that effectively did was do away with 2,000 CPT codes. And it's, they think that is going to really help getting carriers more on financial stability. V28 makes clear how diagnosis codes affect risk adjustment factors, which directly impacts revenues per patient. You know, that's why they all have us do those HRA, those health assessment things whenever we sign somebody up, because it means more compensation to the carrier. The V28 requires more specific and precise documentation, and this is going to affect the providers greatly in that it will require them maybe more of a load on their staff. And I think that could be directly related to why some carriers or some providers are pulling out of the Medicare space, as they don't want to incur the added workload or cost that the V28 requires them to do as far as documentation. There are some acronyms that float around if you review V28. The big one is the coding requires what they call MEET: monitoring, evaluation, assessment, and treatment. And you know, this V28 is one of the things that is really going to impact the star ratings, because of the burden it's placing on providers. Just a couple of acronyms that maybe you should be aware of going forward. Of course, we all know what MLR is. That's medical loss ratio. But one, again, is if you see in documents, you'll see that RAF, which is risk assessment scores. You're going to see PA everywhere. That stands for prior authorization. There's one out there they call FAIR, which is FHIR, which is Fast Healthcare Interoperability Resources. You'll see EHR, which stands for Electronic Health Records. API, which is Application Programming Interface. Of course, there's the Electronic Medical Record, which is EMR. And all these things play into V28. You know, you can go to AI as just on your own and look up V28 and Medicare, and you're going to see a real breakdown on how that V28 is going to affect everything. Bill asked if we can get a list of those codes. I can put those in a document and send those to Morgan, and Morgan can send those out. Next slide, Doug. Why changes matter for Medicare Advantage plans and their treatment of agents. Revenue pressures on carriers, star ratings, of course, the flat reimbursement amount for this year coming up. Because of V28, there's fewer billing options. Lower RAF scores mean lower MA payments. And that V28 indirectly influences STAR performance because of the oversight it provides. Now, some of the things that impacts is documentation burden, higher security against internet hacking, so to speak. And it also increases, and I don't know if we'll see this or not, but it's going to increase providers to increased audit exposure. And I think that's going to be a key place where CMS is going to be looking. So one of the things I think most of us have seen is we're seeing that carriers are not as responsive as they've been in the past. I think we have all seen that. Greater competition in-house and independent selling channels. We're going to see that. And then, of course, there are going to be fewer lead programs, but we have a solution to that we'll discuss. Do you want to move to the next slide, Doug?
It's a question.
Here we go. Does the CMS risk adjustment model V28 require greater specificity in the use of monitoring, evaluation, assessment, treatment, and documentation framework? That one you could have walked away from and just come back, walked away for an hour and come back. That's a pretty easy one. Let's go to the next one so we can stay on time. How do these changes affect beneficiaries? Number one, even though it's not listed here, number one, these changes affect beneficiaries in making you, the agent, much more valuable than you've ever been in the past. It allows beneficiaries with all the new information that will be at your fingertips. They'll be able to see, and you'll be able to discuss with them prior authorization and denials rates. It'll give you a chance to talk about what carriers are best for care management, quality income outcomes versus fee for service. I think outcomes are going to be at the top of the list when beneficiaries start looking at those denials and prior authorizations. It's always easy to look at deductibles and changing tiers. That's all important. That program we were talking about that I lost for a second is called the Medicare Prescription Payment Plan, and some people call it smoothing out the amount of money going out the door, spraying it out over the whole year instead of being front loaded in the first quarter. Declining value of healthcare. I think we're seeing the tip of the iceberg when it comes from carriers resetting Medicare Advantage simply because of the reimbursement coming from CMS. We're going to see carriers pulling back more and more, and which affects, of course, the quality of retirement. So I think, again, the whole point of this is you become the agent, you become an invaluable component to beneficiaries. Next one, Doug. So here are some takeaways for agents. Responding to all the disruptions in the space, agent engagement and education is the key. No longer, I think, is it good for you to say, I only sell X, or I only sell B or C or whatever it is. I think your education as an agent will go hand in hand with you not only maintaining your book, but growing your book. So here are some keys we used to always use when I worked with agents when I was the director over at United. Number one, you need to know the industry. You need to know your product. You need to know your carrier. You need to know your client. And you need, more than anything else, you need to know the options that you can present. You know your value proposition. phenomenally good at bringing value to the table. One of the studies we looked at is that only 40% of agents are conscientiously serving their clients and earning their residuals. Gone are the days of sign and done attitudes. I saw that many times at United, that we had agents who one and done. I sign them up. I don't ever have to talk to them again. If they call, I just tell them call customer service at the carrier. Don't bother me. You, the agent, you are the best resource. And those agents who are the 40% who are fully aware of their job and the resources they have and the knowledge they have, you are the best resource for beneficiaries dealing with the complexity and frustration. And the attitude is, my business is you. And that's something you need to portray your clients. Next one, Doug. So agent growth, you all know, and adaptation. You all know that change is constant. But you also need to understand that in chaos, there is always opportunity. If you look at the cloud and you see the silver lining, even though there's clouds, the rain the clouds produce do great things. So I think there's some opportunity there in chaos if you have the mindset to look for the opportunity. The big thing is T65s. We're going to go over that in a minute because it's a way for you to have a steady stream. The business to business model. This is something that if you look below B, you'll see business to business sales equals a constant flow of qualified leads. If you have not considered going into the business to business model, you're losing an opportunity to have a constant flow of qualified leads. When we have agents are looking to move to Stonehill, or when they move somewhere else, the first thing that comes out is, well, what kind of leads you provide? If you get into the business model, you get in a position where you're going to have a constant flow of qualified leads. If you make the connection with AR, you talk with them about their employee health plans, because there's things you can add to that, such as Phoenix and Select Health MSAs. We also have a wide portfolio, a deep portfolio of voluntary benefits that rival anything you see in the marketplace. The portfolio we have on voluntary benefits, we even have a specialist in-house, Kevin, that can help you with voluntary benefits. But you can stay ahead of the curve, because if you make that connection, you can have a constant flow of T65s who are still working, benefits the employer, benefits the employee, and it benefits you, the agent. It's a win-win across the board. You can harvest new to Medicare commissions instead of just renewals and replacement commissions. So, Doug, you've got a quote down here in the bottom. I want you to talk about anything worth doing is worth doing poorly. Will you talk about that, Doug?
I will for just a second, because we got to get the polling questions going.
Yes.
The expression usually goes, anything worth doing is worth doing well. But what that means is, if people think about that particular expression, what actually ends up happening is they think, well, if I can't do it well, then I'm not going to do it. But anytime there is a new opportunity, anytime you're learning something, anytime you're having to tackle complexity that you've never tackled before, if you have the courage to tackle it, you have to know that you're going to do it poorly at first. And so what she's saying is, anything worth doing that's brand new is worth doing poorly, worth feeling silly, worth feeling crazy, worth feeling like you just don't know what you're doing. You have to pass through that process in order to develop a skill and to become good at it so that you can do it well. In other words, you have to do it poorly before you do it well. It's just the learning curve.
So the big takeaway here is this is a new market segment that I would say 90% or more of our agents don't understand. The new market segment is business to business. And as much as you are valued by your clients, you can be valued by the HR connections you make and business connections. And it will absolutely furnish you a constant flow of qualified leads that you don't have to fight with other agents for. It's just going to come to you as a natural part of business to business, and you making the connection to HR groups and establishing yourself as the go-to resource, number one, for voluntary benefits and health plans for their employees turning 65. Doug, what's the next one up? Here we go. Another question. Which of the following is presented as a strategy for agent growth and adaptation in the turbulent market? A, focusing solely on high premium Medicare supplement plans? No. Expanding to new clients and markets by building business to business? That's the obvious one. And I hope if there's anything you take away from the last 2 hours is your future depends on business to business relationships. That is the golden ring on the carousel, and you need to grab that. Next one, Doug. I'm going to jump in for a minute while you guys are doing a poll. There is the number coming out right now on OEP is it's a high number of beneficiaries are making higher than we've ever had before, making changes to OEP. So again, constant contact with your book of business will really help you not only retain, but those who want to move, you can assist them in doing that. I personally want to thank everybody for participating. Those who participate, thank you so much. But thank you for being here. It's been great to talk about these things and kick around different ideas and see some numbers. And I'll end my part by just saying thank you so much. Back to you, Doug.
Well, I have to echo that. I'm very grateful that you guys came. I hope you have a good weekend.